policy that focus on the population approaches, and preventative approaches that focus on health hazard. So food safety regulation, tobacco control strategies, and other strategies against non-communicable diseases. These are health policies that are rather non-medical. They take into consideration broader societal aspects. So now there's an overlap between these two more or less ideal typical policy sectors. For example, there needs to be a capacity to treat epidemics or big occurrence of infectious diseases. Or another overlap would concern individual health counseling, for example, by GPs, and providing vaccinations to individuals, etc. So it's against this background that I posed the following research question, or the book posed the following research questions. How do these two policy sectors co-evolve? So coevolution means how do they develop under mutual influence? And why are there potential differences between countries? So, and starting from these research questions, I explore basically two big dimensions in how these policy sectors can be related. One is the institutional, how they're distinctive institutionally. This means how are they related in terms of ministries and the administrative structure, and how are they related, or how do these principles relate, these sectors relate in terms of big and important health policies that have been put into place. The second dimension I look at is responsiveness, and that's how do actors or professionals that work in health, or bureaucrats that are related to health, how do they relate these to the preventative and curative, or the healthcare and public health approach? Do they combine it in politicizing health policy problems, or do they only focus on one specific dimension? For example, are doctors and medical organizations mainly concerned with the governance of healthcare and related things, or do they also make preventative matters, non-medical health policy issues, political priority? These are the two analytical dimensions that guide my analysis. So then, to have some, I posed the question: why might there be differences between countries? And therefore, I use some broad theoretical ideas that we find in the comparative politics and the comparative public policy literature. So, firstly, the relationship of healthcare and public health should depend on whether government is unified, either nationally, in the sense that there is few powers devolved to subnational units, or government can be unified in the sense that at the national level, the party that's in government, the government coalition, can actually make big policy changes on its own without having to take into account the balance of power, etc. The second theoretical prior is a bit more complicated and maybe also more innovative intellectually. I'll try to explain it to you ex ante, but I hope it will become clearer once I focus on the examples. So I hypothesize that if professional actors are politicized, and there is some competitive interest aggregation, for example, in liberal market economies, health professions make or combine preventative and curative, or healthcare and public health in their political activity. Why is that the case? Liberal market economies, such as the US, emphasize broad skills. So it's relevant economically if you invest in formations, or if you acquire very broad skills. And you will also define your professional interest broadly. So as a doctor, you will acquire broad knowledge of health, and also the education system is defined in that way. On the other hand, in more coordinated market economies like Germany, skill acquisition is focused on specific skills. And then you have all kinds of social security to cover that. So doctors will also think more, or will focus on more specific tasks and competencies. Consequently, these health professions and the organizations related to them will act politically from that perspective. The second logic from that perspective, and in more liberal market economies, health professions will take a broader approach that combines a preventative and curative approach to health policy, independently of whether they succeed politically or not. Whereas it's not the case in coordinated market economies. The second part of the argument is about competitive or about interest aggregation. If interest groups need to compete for attention of policymakers, they have an incentive to also take into account public health matters, for example, the health professions, because this way they can show that they care about the public health at large, and which will increase their legitimacy cloud for cases when they lobby for their special interests. Again, in coordinated market economies and corporate systems of interest aggregation, there is no incentive to do this because any interest group is basically included automatically in the policy process. And the third theoretical argument would be context matters. So specific health problems in a specific time, specific technological advancement will impact on how whether preventative or curative approaches are dominant and how they are related to one another. To explore these arguments empirically, I conducted case studies of 5 countries that vary on these explanatory dimensions: Australia, Germany, Switzerland, and the UK. So I started from federal states, and then I added the UK as a non-federal state, and the US also. I look at the long time period of 1880 to 2010, and well, what I did in the PhD and what I do in the book, it's like I analyze secondary literature, documents, and I do some interviews with stakeholders and experts. And I also do some descriptive statistics of the reforms that were done. Of course, there is some limitation to this kind of analysis from the perspective of an historian. It's a very high level engagement with the specific problems, and the interviews they cover, of course, only the more recent period. So you have to always keep in mind there is an imbalance. I have more information on the recent periods than on the historical periods. Nevertheless, I'm able to show some interesting results. The first point I'd like to make is about the coevolution of healthcare and public health against context and against the contextual developments. For example, during the first time period, I define 4 time periods rather schematically along big historical events. And then I look into them to probe my hypothesis a bit. So the first period that covers the emergence of the modern state, when modern society was really formed, and state institutions were set up, bureaucracies, social policy in many countries were formed and also nationalized. Infections were the main health problem. So the main challenge for policymakers was how to deal with infectious diseases and how to prevent them. Medical technology was extremely limited, and medical knowledge was also very, very imperfect. So what happened in the UK and Australia and in the US, for example, was a lot of public health laws that were set up and tried to govern all kinds of health problems, such as foodborne diseases and so forth, measures to try to contain tuberculosis and so forth. As not only in the Anglo-Saxon countries, but all in all countries. So these things we observe to different degrees in all of the countries. In the second period after the First World War, there's an advancement of medical technology, but prevention remains important. The big change, or the most important change, is after the Second World War. Once there is a shift towards individual healthcare, so it became now possible to develop or to cure many diseases, notably to antibiotics, but also other things. And it was now possible to cure diseases, and it became economically attractive to become a doctor. And policymakers discovered now that the most important problem to solve was how to finance healthcare and how to make it accessible. That there are different models in different countries on how this was done. This led to a dominance of a focus on individual healthcare in many countries. We could also argue there was a period when many public health problems from the second half of the 19th century were actually solved because it was possible to cure the disease that had to prevent it then. And the fourth time period, there's a return of public health. I already mentioned that when introducing the talk and the book. Then we have new infectious diseases that come up like HIV and influenza stems and so forth that remain problematic, and the non-communicable diseases are a problem. Non-communicable diseases are a problem because populations, people tend to get cancer and diabetes, etc., due to lifestyle-related behavior such as smoking and an unhealthy diet, etc. To make the point, or if you look at health expenditure nowadays, or in the development of health expenditure since the 1970s, it's a quite clear picture. So this is OECD data. If you look at the classification of health expenditure, most is on curative medicine, and a little bit compared to that is on prevention, between 2 and 5% of what countries spend on healthcare, and the rest that is not in here, it would be on administration, etc. So this is a rather, and this is valid. This is like the average across OECD countries. So there's not a lot of variation. Then what I did to analyze the coevolution in policy of healthcare and public health, I did a survey of reforms in different time periods, and I coded the various reforms, health policy reforms, either whether they belong to healthcare according to the scheme that I showed before, or whether they rather emphasized public health matters, health protection, or if they somehow integrated or coordinated the two dimensions. And based on that coding, I can indeed show that I can also show that there is a coevolution that we start with public health policy, what I just said, in the first time periods, then healthcare becomes more important and somewhat dominant, but there's also a rise of so-called integrated health policies that look at specific health problems by taking preventative and curative approaches into consideration. So the next question is then, how does this affect countries? So what's the difference between countries? And the 5 countries in my analysis show well, a lot of similarities and some differences actually. If you only look at the formal reforms of the health system and the way they coded it, we see that indeed in all countries. Now we see here we see the dark points is the public health reforms were most prominent in the formation of the modern state, and healthcare reforms followed on that. The only country that's really an outlier is Germany, and the story behind this is simply that in Germany there was a national health insurance law which was set up in the late 19th century, and this became the main reference for governing health policy at the national level. And preventative health policy was often dealt with either at the subnational level, or policymakers tried to insert it into a health insurance scheme. So it was the health governance went through this perspective. In all the other countries, we see more or less the pattern that I described before. So now I will go through the countries, and also I will say something about the explanatory factors that I discussed before. So the responsiveness between sectors through the political activity of health professions, and the importance of unified government at the national level. So if you look at the responsiveness of health professions, my case studies show that in Australia and the UK, we have many instances of health professions broadly defined, making health policy or preventative health policies a political priority by broaching them publicly, by addressing policymakers and elected officials to actually do something about this. In the US, it's similar. There is a similar degree of political activity, especially regarding tobacco control. To the contrary, in Germany and Switzerland, I find little or less evidence from the case studies that the health professions make preventative policies a political priority. So, and I base this on the reading of the secondary literature, and for the more recent time on some interviews with these actors, but also with other researchers and with third parties that observe health professions. To further prove this point, I do also have I did an analysis of statements in the newspapers on tobacco advertising restrictions and related public health measures. So this is from another project that I did. And there we see these statements that were done in favor of regulating tobacco advertising or alcohol advertising and so forth, or something that was related to that. And these are statements in favor of this. Again, during the data starts in 1991 and it ends in 2013. Unfortunately, it's not very well not see it very well. And what I compare here is like domestic health profession and interest groups. So if the newspaper reports to the National Medical Association or the National Cancer Council says, yes, we need more tobacco prevention. Or if the newspaper reports the political activity of the health professional organization abroad. So for example, in Switzerland or in Germany, there would be a newspaper article saying that in the US, the Medical Association or the Tobacco-Free Kids demands reforms in that end. Then I compare it to economy-related interest groups such as tobacco industry, but also publishers' organizations and so forth. And there we see again that there is a difference in the relative number of statements voiced. So this provides some evidence for the case that there is indeed a difference in health professions' political activity. The second point, or the second theoretical prior I had put forward, concerns unified government and the strengths of the state. And there the case studies reveal that there is a top-down governance of the relationship of prevention and cure. In the UK and in Australia, the national government manages the relationship of preventative and curative health policies, and with using a lot of executive coordination between the different states. In Germany, as I said already, healthcare corporatism dominates health policy making, and which complicates how to do preventative health policy, and it gives a lot of leverage to interest groups that oppose preventative health policies. For example, the case in point is that it took Germany until 2016 to put in place a framework law for preventative health policies. Before that, there was just an agency that was under control of the Ministry of Health that could do that, but there was no legal basis for doing preventative health policy at the national level. It had somehow to be included into the social insurance legislation and the health insurance legislation. So, and this has changed only very recently. But still, German corporatism is very well known for, or Germany is very well known for being very receptive to arguments of the tobacco industry, and arguments against doing tobacco control policy. Switzerland is very similar to Germany, but they're the subnational governments, so the cantons play an important role because they have a lot of autonomy. And in the US, the national government traditionally focused on public health, but the states play a very important role. So in the US, it's also interesting. We see health professions and related actors are very active politically. They demand reforms, but this does not, or to a very limited extent, result in big national reforms because of the balance of power at the national level, because of the discretion of the states in many health policy areas. So these are the main points I wanted to present. Or these are the main case studies. So to conclude, the book analyzes healthcare and public health as two different policy sectors. It's a new analytical perspective on health policy because they actually focus on preventative and curative as two different policy sectors. If I would make the economic case, we could disregard it quickly, but I think there are some important reasons to consider that both perspectives should be valued equally. Certainly, because preventative health policy, well, it does not cost a lot. The budget would be inserted into other policy fields, and also because it's rather a regulative policy approach. And then I demonstrate the political activity of health professions matters indeed for how preventative and curative policies are related in discourse, and I also discuss how centralized government or the centralization of the state affects the relationship of curative and preventative health policies. And eventually, context matters for the coevolution of the two sectors. This means the technology that's available, and then the health problems that prevail in a country and are on the political agenda. Thank you very much for your attention, and I'm looking forward to questions and comments, and be happy to